what is the pattern of maturation, whether it is active and normal pattern of maturation. Okay. Then any dyspoiesis in any of the lineages, any abnormal cells, and then pulse is a very important stain to do. So not just for iron stores, but also if there are any ring sideroblasts. So don't stop at seeing only at the low power, but go on to the high power and see whether any ring sideroblasts are there. Then of course, cytochemical stains depending on the case. So these are very basic aspects of a bone marrow aspirate. So what we have today is 6 cases, and the theme of the slide session is like this. Cases 1 and 2, we have called it too many E-residents. 3 and 4 are missing residents, and 5 and 6 are bubbly non-residents. So you will, at the end of the session, you will realize whether the naming is apt or not. So with this, actually, I hand over to Basu sir because he is traveling. And after that, I will take up cases 1, 2, and 3 after he finishes 4, 5, and 6.
Yeah, fine. So good evening, everyone. I'll start sharing my screen. Is it visible?
Not yet, sir.
Not yet? Okay.
Not yet, Basu, not yet.
Yeah, just a minute. I'll go it.
Yeah, take your time. Yeah. We can see it now.
Now you're clear? Case 4. It's visible to everyone. Please just tell me.
Yes, sir.
Okay, great. So we'll have this case. I've sent out the history to all of you. So who will take it up? Will anyone volunteering?
I'll take it, sir.
Ritu, you're taking? Rituraj?
Yes, sir. I'll take it.
Great. Okay. So pick up. Why don't you read the history and let us know what you make out of it?
This is a case of a 60-year-old retired bank officer, known case of chronic kidney disease on regular hemodialysis for 2 years. He had a refractory anemia. There are no organomegaly or bleeding tendencies. Hemoglobin ranges from 4.5 to 5 gram per deciliter in his last 6 months. And he has also received packed red blood cell in last 2 months. He is also receiving external erythropoietin, but hemoglobin has not improved then. Currently, the complete blood...
So could you just quickly tell us from the history, what is the thing that you think of?
So this is anemia of a chronic disease.
Yeah.
Chronic kidney disease.
Right. Anemia in the chronic kidney disease. Okay. So just tell us the values.
So currently the patient has hemoglobin of 4.8 gram per deciliter with MCV of 96 femtoliter. Retics count is within normal range. Total count is 7600 per cubic millimeter, and differentials is neutrophil 58, lymphocyte 35, monocyte 5, and eosinophil 2. With platelets 1.78 into 10 to the power 9 per liter.
Right. Just 1 point. The retic count is not really normal, 0.1%. So what is the normal retic count if you just look at it? Retic count normally is about 0.5 to 2.5%. Even if you correct it, and a 0.1% retic is definitely a low retic. So we have a case of hemoglobin 4.8. So severe anemia with a reticulocytopenia. So isolated red cell disorder is what is coming out of it. MCV is borderline on the higher side. It's high normal.
Towards the higher normal side.
Higher normal. Perfect. Differential count, total count, platelets are all adequate. Okay. So what do you the indication of this bone marrow to be done was a refractory anemia, right? So just now Dr. Rakhi called. What do you think is the cellularity of this marrow on the aspirate?
For 60 years of male, the cellularity is within normal range, normal cellular for age.
Right. I hope you all are aware of how to assess the cellularity. It's best done on the trephine biopsy, but still on this roughly 100 minus age is what is taken. So this is kind of a normal cellular marrow. Right. So what did you see in the slide that was given to you?
In this slide, we can see hematopoietic cells. A few erythroid precursor cells can be seen here.
Ritu,
with
can you tell us which specific hematopoietic cells have you seen?
pro-erythroblast,
What
sir.
hematopoietic? Yeah, I'm circling. These are the erythroid cells, right?
Erythroid, yes, sir.
Okay. What about the rest of the field?
In the rest of the field, neutrophilic maturation is also seen. Neutrophils are also seen.
Basically, a lot of myeloid cells with
And
proper maturation right up to the stage of neutrophils, right? Occasionally eosinophils. And there are these couple of erythroid cells, which you call them. So what do you think is which stage of erythropoiesis is this?
this is pro-erythroblast,
Yeah.
maybe, sir. These
So
are
roughly,
too
this
large.
is the slide that was given to you, right? So roughly, if you were to see this in all the slides, roughly what would your ME ratio be? Myeloid to erythroid ratio?
Myeloid is higher in myeloid to erythroid ratio. Myeloid is better, has a higher ratio than erythroid, sir.
Yeah, that's normally. Normally, what is the ratio? ME ratio?
2:1 to 5:1.
Right, right, perfect. 2.5 or up to 5:1. Right, so more myeloid cells. Here in this field,
In this field, we can see erythroid series with mature erythroid precursors.
is there
And
erythroid maturation going on in this field?
we cannot see
You
orthochromatic.
cannot see, right? So
We
the
cannot
ME
see.
ratio roughly, I'd say, is about 20:1, right? 20 myeloid and just a few erythroid cells, right?
Few erythroid, yes, sir.
Yeah, so let's move to the next slide. Yeah, what do you see in this? This is again a slide that was given to you.
Yes, sir. This can be a proerythroblast series, sir,
Fine.
with
So this,
two prominent nucleoli within the within the cell. Very large
notice the
cell.
typical blue cytoplasm, kind of a very immature looking nucleus and
Yes.
two prominent nucleoli. So this would be what is called a proerythroblast. Would you like to comment on the size of the proerythroblast, or at this point you would just label them as proerythroblast, right?
These are larger cells than even larger than neutrophils. So
Yes, much larger than the neutrophils.
much larger
right?
than
So it's
neutrophils as
pretty,
well.
pretty large cell, right? So it's an early precursor. Okay. So at this stage, there are two questions for you. Ritu, what are the causes of anemia in just kidney diseases? So what do you think are the causes of anemia, and what do you think is the cause in this particular patient?
So
Just based on these two photographs. Yeah.
in chronic kidney disease, the main primary cause is decrease in erythropoietin production.
Right.
One of the major causes is decrease in erythropoietin, and another condition is increase in hepcidin level. That also causes anemia.
Okay.
Other nutritional deficiency can
Yeah,
also occur
those are
in
safe.
chronic kidney disease.
Any other cause of anemia related to the kidney disease as such? Related to the kidney?
Hyperparathyroidism is one of the cause for
Okay, that could also be
chronic
there,
kidney disease.
secondary, right? The uremia per se, high urea
Uremia.
levels is actually toxic to the hematopoiesis.
Yeah,
Okay,
uremia is also.
hematopoiesis, that itself. So higher the urea levels, more are the chances of slightly kind of suppression of hematopoiesis. In addition, depending on the type of kidney disease, suppose it's one of those hemolytic uremic disorders, syndromes, you would get hemolytic kind of an anemia. Or if it's a tumor or a stone in the kidney which causes blood loss, you could get anemia. All right, iron deficiency anemia. So the causes for anemia in chronic kidney disease is vast, is myriad. Lots of parameters are there, lots of factors are there which lead to anemia. But as you rightly says, the primary cause of anemia in chronic renal failure is the deficiency of erythropoietin. Fine, very good. Okay, so what do you think is the cause in this particular patient?
Might
Or
be.
would you like to take this question later on after we have seen the case?
Okay, sir. That is also fine, sir.
Okay, so all right. Okay, so now I'm going to show you a few more pictures, and this is for everyone in the audience. Again, something very similar to what we saw. There's again a pretty cellular field in the marrow. Notice a lot of myeloid cells, myeloblasts, there are eosinophils,
Yes, sir.
metamyelos, neutrophils, and caught up in all that are a couple of, again, those large, which I'm pointing out, large
Erythroid cells.
immature erythroid,
Immature
pro-erythroblast.
erythroid cells.
And in this field, again, I do not see any maturation of the
Maturation.
erythroid lineage. Right?
Yes, sir.
Yeah. Again, Ritu, anything else you're seeing in this? Just a higher power of the same?
Same. We are again seeing immature erythroid cells, sir.
Yeah, just So what we can call it kind of a maturation arrest.
Maturation
Right? They're
or
not
seen erythroid series.
proliferating or maturing beyond the very early proerythroblast stage, right?
Yes,
The rest
sir.
of it is all myeloid.
Yeah, myeloid series are progressing, but
Yes.
erythroid series is arresting, sir.
Yeah. Again, this one, right? Here's another
Yes.
one which has kind of these what are called the dog ear or the slightly blebbing of the
Bleeding of
cytoplasm.
the cytoplasm.
Yeah. And notice here, what else does this cell show?
These cells show intranuclear inclusion, sir.
Almost like an inclusion, like intranuclear inclusion, right?
Yes, sir.
All of you, I hope you've got these pictures. The rest of it is again some lymphocytes and myeloid cells.
Myeloid cells.
Yeah, again another similar.
The cell in the center shows intranuclear
Again, very
inclusion, sir.
prominent
Again.
nucleolus. Yeah, I've got it on the higher magnification, almost like a glassy intranuclear inclusion. Right. So what does that tell us? What is the importance of noting these inclusions, big inclusions intranuclear?
Infective cause, maybe parvoviral infection.
Yeah, possibly. That we can keep in mind. Parvoviral infection, right?
Yes, sir.
Fine. Good. Good. Again, I just wanted all of you to appreciate these large cells. They're all proerythroblasts, giant proerythroblasts. Some of them have very coarse, proper nucleolus or inclusions, and others do not. But also notice this dog ear type of an appearance that they have, right? So, along with that, the bone marrow biopsy was also received. So, as always, they are complementary to each other. We do it at the same setting, try and do it at the same setting. So, we received a 2 centimeter long core. And again, these slides were sent to you.
Sir.
What do you see here, Ritu?
So again, in this picture, in this biopsy picture as well, we can see some cells having pale-looking cytoplasm and prominent nucleoli pushed towards the periphery of the nucleus.
Yeah, very pale-looking nucleus, not cytoplasm.
Nucleus.
Cytoplasm is
Sorry, nucleus. I mean to say nucleus.
Yeah, I know you meant it. Again, a lot of myeloid cells in the background.
In the background.
There's another one here in this particular field, the lower half.
And there is a nucleoli.
Yeah.
Push towards periphery of the
push towards the periphery, right? Perfect. So this was on the lower part in that same biopsy. Again, if you notice, strikingly, there are these 2 cells,
yes, sir,
which are visible in the background of myelopoiesis going on. Here's another one, slightly like that. Rest of it is more or less normal, excepting erythropoiesis is not going on.
Oh.
Another high power view of the same.
Similar.
One cell with a kind of an inclusion. Yeah, the rest of it is myelopoiesis and lymphocytes. Similarly, another field. This is for all of you to see. Slight increase in eosinophils in the background. That's okay. Right? So this is, how would you identify them as erythroid cells? Suppose you are searching for them, or how would you highlight, what would highlight erythroid cells? Ritu?
Erythroid cell. E-cadherin immunostain, sir.
Okay. E-cadherin is a good immunostain. It highlights the early forms or the dyspoietic forms. So does CD71. But E-cadherin we use and we found very good results with it. Glycophorin is another erythroid lineage marker, but that usually in tissue sections highlights the mature forms. So often it causes, if your biopsy is kind of hemorrhagic, using glycophorin can be very disturbing. So it's a good marker. E-cadherin is a good marker for erythropoiesis. So this is how we got it, one of the cells. It also helps you identify, if you're looking for these erythroid, which is arrested and which are very few, E-cadherin often helps. Similarly, another one, right? In this whole field, you see a few which was highlighted by E-cadherin. It's a good marker to use. Also, it's useful in when you're dealing with myelodysplastic syndrome or refractory marrows or marrows and remission for leukemias. When you want to highlight erythropoiesis going on, it is a useful marker. All right. Now, in addition, so this is basically a red cell aplasia. As you know, in constitutional, it is the Diamond-Blackfan syndrome, but acquired, either virus-induced, and that is common in the hemolytic anemias. Patients with hereditary hemolytic anemias often have an aplastic crisis related to parvovirus. It is also a feature, at times can be seen in SLE and other autoimmune diseases. It can be seen in CLL, thymoma, large granulocyte LGL leukemias, and in renal patients, renal failure patients who are on erythropoietin, apart from the virus, it is acquired erythropoietin antibodies. That results in red cell suppression. So that's another complication of erythropoietin therapy, is the acquisition of antibodies to EPO.
Erythropoietin.
Right. Now, what else did this marrow show? So what additional findings did the bone marrow trephine biopsy show, and how would you further investigate it? I had sent another photograph of that.
Yeah. In other biopsy pictures, we can see bone marrow fibrosis as well.
What does this picture show? I had sent this across. What does...
Yeah, the bony
Can you tell us?
trabecule is somewhat eroded, kind of eroded, sir.
Yeah, right. It's not a regular. Very good. It's kind of eroded, scalloped. It's kind of
Scalloping.
a little, scalloping is there, and there are a few osteoclasts. Notice even on the low magnification you can make out. We generally use the Hammersmith protocol or the AZF fixative followed by formic acid. So that brings out the decalcification is quicker and morphology is well preserved. So what you notice here is a very irregular trabecular outline, and there is a bit of a scalloping or what is the beginning of a tunnel. And there is this osteoclastic rimming, and also there is this peritrabecular, paratrabecular fibrosis, and osteoblasts are lining it. So what do these things imply? What does it imply?
These are the features of renal osteodystrophy, sir.
Okay, fine, very good. This patient is a long-standing patient of renal disease on dialysis. And this is again another field showing kind of a polytrabecule, which is showing a paratrabecular fibrosis. And the rest of the marrow is more or less normal. And again, if you look at the previous slide, you hardly find an erythroid cell. It's entirely full of myeloid. So in addition to red cell aplasia, this bone marrow biopsy showed features of renal osteodystrophy. And you could, if you use the reticulin stain, and what is this stain, Ritu?
Mason trichome, sir.
Yeah, very good. That's the Mason trichrome to highlight the collagen. You can identify the paratrabecular collagenization, increase in reticulin. So all these features are a part of what is called renal osteodystrophy. Right? Okay. Yes. So the take-home points, as I said in this, is anemia and kidney disease as myriad etiologies. PRCA is either due to viral or currently because of erythropoietin therapy, antibodies to EPO. Renal osteodystrophy, one doesn't do a biopsy for renal osteodystrophy, but it's an incidental finding that you can pick up, can be diagnosed on the bone marrow biopsy, and contributes not just to the skeletal problem, but also the hematological manifestations. The suppressed hematopoiesis, one of the reasons is this development of osteodystrophy. And bone marrow aspiration and trephine always are complementary, and each one giving some idea or some information that the other one doesn't. Okay, so with this, if there are any questions, I'll be happy to answer. Ritu, any other doubts or any clarifications you want? And the others also, please, 7 of you, and also in the audience.
I've read somewhere hyperparathyroidism also causes erythropoietin, downregulation of erythropoietin receptors.
Yes, yes. This renal osteodystrophy is actually a part of the secondary hyperparathyroidism that sets up in renal failure.
Yes, sir.
Okay, so the whole thing is linked to each other, and that also causes the hematological manifestation, anemia and cytopenias that develop is because of development of secondary hyperparathyroidism.
Sir, there is a question in the chat box. Why does the virus have affinity particularly towards immature erythroid cells?
Oh, that I think we need to. Is there anything like that about the virus being implicated? Parvovirus B19. I'm not too sure, but it is kind of erythrotropic. I have to find out as to what exactly it binds to in the erythroid lineage. That I'm not sure, but it is always known that it is only for erythroid. It's a parvovirus. Otherwise, is a very non-specific. The fifth disease, and it's a non-specific self-limiting viral infection that happens with parvovirus. But in a setting of hemolytic anemias, and as well as in patients on renal failure and prolonged dialysis, it is responsible for erythroid suppression. If anyone knows the exact pathogenesis, please, if you could tell me, I'd be happy to also know.
Sir, I think there are no answers
Okay,
for that.
we'll find that out. Okay,
Yes,
that's a
sir.
question. That's a little question that I have to do the homework on. Fine, thank you for
Yes, sir.
putting up this question.
And just for clarification, one student is asking, so the final diagnosis is PRCA for this case?
Yes, PRCA along with features of renal osteodystrophy.
Yes, sir. And another question is, we didn't see any megakaryocytes in the section studied.
Yeah, I did not. I did not focus on areas of megakaryocytes are kind of localized. Those areas where I was trying to take the picture for the erythroid, megakaryocytes were unfortunately not there. There was adequate megakaryopoiesis in this picture, but just for showing the photographs, I had to take photographs where the erythroid cells were present. In those areas, unfortunately, megakaryocytes were not there.
Yes, sir. So there is the one answer for the question that why virus affects the immature erythroids. One of the answers is because it has a tendency to affect the glycosylation involved in the ABO antigen receptor formation,
Okay, fine.
which is the receptor for parvo.
Virus. I also thought so.
Yes,
Probably the
that is one of
ABO
the
group
answers.
antigen. Yeah.
Yes, sir. So there are no more questions for this particular case. I think we can move on to the next case.
Next case, right. So case number 5, who will take up?
I can take it.
I can't see you. You are?
Dr. Pranjal Shah, sir.
Pranjal, you're taking up. Okay,
Yes,
great.
sir.
Take up.
Yes, sir.
So case number 5, again, we sent you a photograph of a 5-month boy. Failure to thrive with abdominal distensions since the first month of life. Fever on and off and bleeding from vaccination site. Right. So could you interpret the history, Pranjal?
Yes, sir. So from the given history, it is a 5-month-old. So it is a disease which is like childhood disease, and from the history, it could also be because of, say, malnutrition, sir. But coming back to the
Malnutrition would not cause bleeding from vaccination sites.
right, sir.
Fever, yes. So, and if you look at it, there's a big liver spleen. So, would you
Yes, sir.
take that and
Yes, sir. So it could be infectious disease like infectious mononucleosis, or say hepatitis, or
in an infant with a big liver spleen, I would consider some kind of an infiltrative disorder, right?
right, sir.
And bleeding is possibly because of cytopenias, fever is because of cytopenias.
Yes, sir. So it could be a storage disease, glycogen
One
storage
is a
disease.
storage. Another thing that can present at this age, infancy, is a Langerhans cells, histiocytosis. So
Yes,
some
yes,
kind of
sir.
an infiltrative disorder, which has caused a big liver spleen and
Yes, sir.
failure to thrive, fever on and off. Failure to thrive with a liver spleen in a 5-month, you could think of a hemolytic process, but usually won't cause a massive spleen at 5 months of age.
Yes,
And
sir.
so I would consider some kind of an infiltrative disorder, right?
Right, sir.
Fine. So what are the causes of splenomegaly in an infant?
The splenomegaly in an infant, as we have this case, it could be an infiltrative disease, glycogen storage disease, or sir, it could be hematological disease like sickle cell or thalassemia, or liver disease like hepatitis, or ALL, sir.
Okay,
Leukemias,
some acute leukemias may manifest with a
leukemias.
big
Yes,
spleen
yes,
in
yes.
infant. But yeah, all right. So
Yes, sir.
basically storage disorders or an infiltrative disorder.
Yes, sir.
Right. Anyone else wants to answer that? Causes of splenomegaly? Any other thoughts?
Infections,
Other than
sir.
Pranjal?
Infections,
Yes,
sir.
infections.
Infectious like
At times,
mononucleosis,
the
or
TORCH group of infections may
yes,
present
TORCH
with
group of infections.
hepatosplenomegaly.
Yes.
Congenital tuberculosis may present with hepatosplenomegaly. All right,
Yes,
but
sir.
I think protozoal infections as well.
which protozoal?
Malaria, Kala-Azar,
Leishmania.
Yes.
At infancy, I'm not 100% sure. Within first year can occur, but not right. All right. Let's see what the hematological parameters are. Yeah, tell me.
So on hematological parameters, this hemoglobin is 6 g/%, MCV is 65, which is decreased, TLC is 13,500, and neutrophils are 4350, lympho 5 meta and 2 monocytes, and platelet count is 25,000. So as here we can see there, as we can see here, there is anemia as well as thrombocytopenia in the patient, and abnormal cells like metamyelocytes can be seen.
Let's not call them abnormal. Let's say that
For
metamyelocytes are there, suggesting of a shift left.
shift to left
Yes.
of the myeloid series.
Right.
Yes.
What specific things these two lymph cells show?
Sir, in the subset picture, I can see probably a lymphocyte with vacuoles in it.
Yeah, so there are these vacuolated lymphocytes. Very
Yes.
good. This one
And
also, this picture quality is not too good, but here on the high power, you can see bit of hypochromic RBCs and
yes, sir.
lymphocytes which have these vacuoles in the cytoplasm.
Vacuoles. Yes,
Right.
sir.
So what would you think of vacuoles in the lymphocytes? What are the possible causes?
Sir, my first differential would be Niemann-Pick syndrome.
Okay, let's not again be so specific about Niemann-Pick. A lipid storage.
Okay.
Yeah,
Okay, it
storage
could be
disorders.
a storage disorder, sir.
Not necessarily lipid, even the mucopolysaccharide doses. All those can
Yes.
cause a lot of vacuoles
sir.
in the lymphocytes, monocytes. This particular case, I didn't show you these pictures. The neutrophils also showed vacuoles. Okay,
Right, sir.
you might at times mistake it for toxic change, but no, these are very punched out, well-formed vacuoles, and the rest of the neutrophils look more or less normal. Okay, so this particular case had lymphocyte and neutrophilic vacuoles, right?
Right, sir.
Right. So the indication for a bone marrow in this case was this massive hepatosplenomegaly with cytopenias, and the aspirate was good, particulate, and normocellular. Right. Okay.
Yes, sir.
How would you talk of the cellularity of this case?
Sir, it seems normocellular for age.
For age, very good. And here you can see, what else can you see in this very low magnification when you're looking at the trails? What are these?
Karyocytes.
What are these?
They look like megakaryocytes.
Yeah, so here, in contrast to the previous case, here there are lots of megakaryocytes. So
yes.
when you look at this field, you know that this patient's marrow is cellular. It's cellular for age, it's normocellular for age, and there is adequate megakaryopoiesis going on. So platelets are low, but there is megakaryopoiesis that is still functioning. Okay, right. Then what do you see in this field?
Sir, here I can see late normo blast.
Yeah, at this magnification, I would rather say normoblast. There are erythroid precursors, right? Plenty of them.
Yes. So there is, I
some in
can.
small clusters here and there.
Yes,
what
sir.
about myelopoiesis?
Sir, myelopoiesis is less. So the like ME ratio, it's not normal. There's reversal of
Slight
ME
amount
ratio.
of erythroid.
Yes.
Agreed. Erythroid hyperplasia is there,
Yes.
but I would like to say there are quite a few myeloid cells. I'm
sir.
screening around. Myeloid cells are not too bad.
Right,
They
sir.
are there, but yes, definitely, as you say, there's erythroid hyperplasia. Anything else you can pick up? And this is a very low magnification, 10x.
Sir, not sure.
I'm pointing out here.
Sir, yes, I can see a histiocyte, like vacuolated histiocyte.
Okay. So you can see a large macrophage
Yes.
type of a thing,
Macrophage,
right?
yes.
How many
Yes.
in this field? Now tell me how many are there.
There's one that you pointed. One is in the bottom of
Yes.
the screen.
Another one here,
Yes, sir.
right? All of you are seeing, and the third one here,
And the third one in the center around.
7 o'clock, right? So there are 3 in this field. So once you get a hang of finding one, the others are easy to pick up.
Yes, sir.
Macrophages is often very difficult at low power, but you need to train yourself. See them once and you will not miss them the next time. Okay,
Yes,
because they kind of merge with the background because of their wispy cytoplasm. But notice there are 3 large macrophages over here. Okay, so let's see
Yes,
again.
sir.
Now this slide, I think I sent it to you.
Yes, sir.
What does this show?
So here again we can see in the center there is a vacuolated macrophage, foamy macrophage, along with intermediate and late erythroid series.
Yeah. So
And
there is erythropoiesis which is happening around these macrophages, and that's
yes,
normal.
sir.
Okay,
Yes,
that's
sir.
how erythron is formed. There is a central nursing macrophage which kind of gives it the nourishment, and they are surrounded by erythropoiesis. The
Yes,
same
sir.
thing is recapitulated here, excepting for the fact that these macrophages look a bit odd, right? That's not really normal. They are very punched out vacuoles. Okay,
Yes,
so I'll
sir.
show you a few more pictures of those macrophages here again. A very large cell and with punched out vacuoles. Another one here. And this possibly even shows a kind of what is called an emperipoiesis going on. You have a nucleus of a lymphocyte within the macrophage. Notice,
Yes, sir.
this is one big one, this is one slightly smaller one, still punched out vacuoles, and the rest of it is again another one which is broken up. And the rest of it is erythropoiesis going on. Few myeloid cells, as you said, are here and there.
Yes, sir.
This field,
So, seeing over here, we can see multiple vacuolated
yeah.
macrophages
And now here
along
they are in clusters,
clusters. Yes.
right? They are kind of clustering
Yes.
with each other.
Yes, sir.
Another one, right?
Yes, sir.
Another one.
Yes.
Make a note of the size of the vacuoles. Okay, so what is your thought on this?
Sir, so my first diagnosis would be a storage disease
Right, very good.
disorder,
Right.
which could be Niemann-Pick or say Gaucher's disease.
Mhm.
Uh,
So a
so
lysosomal storage disorder, right?
lysosomal storage disease, yes,
Niemann-Pick
sir.
or Gaucher. So just quickly tell me, what is Niemann-Pick? What is the deficiency in Niemann-Pick? What is the deficiency in Gaucher?
Sir, so in Niemann-Pick, there is deficiency of sphingomyelinase enzyme.
Right.
Whereas in Gaucher's disease, there is deficiency of
Glucocerebrosidase.
gluco. Yes, sir.
Glucocerebrosidase, right.
Yes, sir.
Glucocerebrosidase. Right, right, good. So which one do you think this is likely to be?
For seeing the vacuoles, I feel I'm inclined more towards Niemann-Pick disease. In
More
Gaucher's disease,
towards,
there are macrophages with crumbled paper appearance.
okay, so vacuolated things, so
Vacuole.
possibly a lipid storage disorder.
Yes, sir.
So there's another one full of just clusters of them. So the bone marrow findings, as you have described it, all right. So likely diagnosis, we are thinking of a storage disorder.
Storage.
What
Yes,
are the
sir.
differential diagnosis? Are there other storage disorders other than
Yes.
Niemann-Pick and Gaucher? Yeah.
Yes, sir. There's Gaucher disease. There's Tay-Sachs disease, Hunter syndrome, or
Okay, so basically, if you were to classify them, they come under lysosomal storage or mucopolysaccharidosis group of disorders, right?
yes, sir.
And some of them do involve the spleen and the marrow and the hematopoietic group. Not all, like glycogen storage and all, do not necessarily go into the hematopoietic system. But the hematopoietic system is affected by the entire group of lysosomal and the mucopolysis. So what's the investigation that we want to do?
Sir, I would like to investigate biochemical assay for
Yes, so basically we do a biochemical assay.
Yes, sir.
Anyone else has any other thought? Anyone else maybe in the audience?
DNA analysis for
DNA
Yes, right. DNA analysis, enzyme levels are to be done.
yes,
Definitely
sir.
to be done. But morphologically, any other storage disorder comes to mind.
Wallman's disease.
Wallman's disease.
Wallman's disease can be.
Yeah, Wallman's disease. So how do you investigate a Wallman's disease?
It is a
What is Wallman disease and how do you investigate?
lysosomal storage disorder.
What is the deficiency?
Lysosomal acid lipase.
Lipase, huh?
Okay, right. Esterase and cholesterol esterase or acid lipase. Very good. So what is one important finding in Wallman's, feature of Wallman's, which can be picked up very easily? Any other investigation you would want to do? We ordered just an X-ray abdomen. I'll tell you why I did not really think it is a Niemann-Pick. I'll just show you cells of
Yes,
Niemann-Pick. I ordered an X-ray abdomen and this is what we got. Anyone can identify what's there in this X-ray
Adrenal
abdomen?
calcification.
Right. Beautifully, adrenals were calcified. Right one much more than the left, but it is, you can make out the calcification. And same thing on the ultrasound, the calcification was very nicely seen. And so a diagnosis of Wolman disease was made. It's an autosomal recessive lipid storage disorder, deficiency of lysosomal acid lipase or cholesterol ester hydrolase. The LIPA gene is deficient. It has neurological deficits. It's a very morbid condition to have hepatosplenomegaly, cirrhosis, and classically bilateral adrenal calcification. So I'll just show you, run through a few more macrophages that can be seen in the marrow, one of which is this. This is a normal macrophage. Okay, there's a normal macrophage, very wispy cytoplasm. You really cannot bound it. And it has got these, what is called a tingible body macrophages, the tissues, the cellular debris, it has engulfed. Another one, this is again a macrophage which can be normally seen. We see a lot of macrophages in, let's say, patients of leukemias who are having a marrow, remission marrow for assessment. You see a lot of macrophages in them. This is a phenomenon, again, that I have highlighted, where erythroid cells are seen surrounding a macrophage. What is this process called? Any idea? This phenomenon by which basically iron gets transferred from the macrophages to the erythroid cells. This is known as rhophocytosis. Rhophocytosis, RHOPHEOCYTOS, rhophocytosis, right. Now, this is another case where you notice the macrophages are enlarged, they are not vacuolated, and if you look at them closely, they have what is called the crumpled tissue paper. So this is what you get in Gaucher disease. You can highlight it with PS or pearls or acid phosphatase for your thing. Another case where the macrophages are there, they're again large, very bubbly, but they have very fine vacuoles. Okay, this is what is seen in Niemann-Pick. Most of the Niemann-Pick will show these tiny vacuoles because it's sphingolipid, whereas the other one is cholesterol and esters which are there. So this 3-panel is what I had prepared for all of you. That's a Gaucher, that's a Niemann-Pick, and this is what you see in mucopolysaccharides and Wolman. This is the type of variation that we see, right? What about this? This is a case of a CML, by the way. You can see a lot of myeloid proliferation.
C blue histiocyte.
That's a C blue histiocyte. C blue histiocytes are also rich in sphingomyelin and basically spheroid. The light of our skin. Yeah, so that's a C blue histiocyte. That's again what you see in very hyperproliferative marrows, ITP, CML, etc. What about this? Any comments?
Hemophagocytosis.
Right, that's a phagocytic macrophage, which is, you would get that in hemophagocytic lymphohistiocytosis, hemophagocytic syndromes. Yeah, that kind of they are intact immature cells which have been taken up, right? So that was about the macrophages and the disorder, right? Yes. So storage disorders are not very uncommon, especially it happens in communities where there is consanguinity in marriage. We do get a lot of storage disorders, especially Niemann-Pick and Gaucher are the commonest ones. Macrophages can often be missed because they merge in the background and often are not in plentiful. So you got to really look for them. And one good place to look for them is around the particles. They're there, that pale, empty-looking space often is a macrophage sitting there. Okay, and currently, not too many people are doing marrows for storage disorders because we have enzyme and genetic diagnosis getting available to most places. But it's a good learning exercise to pick up marrow macrophages and macrophage disorders in the marrow. Right. So any queries or any clarifications, questions, I'll be happy to take.
No questions in the chat box. Most of the responses are answers to your questions to the students over here.
What we had asked. Okay.
Yes.
Fine. So shall we move on to the 6th case?
Sir, there is one question. How does the pearl stain help in these cases?
Yeah, pearl stain is useful because Gaucher cells are highlighted by pearls. They are often pearls positive, not the others. Pass stain is good for Gaucher. Pass stain is negative in the lipid storage ones. If you have facilities for your lipid stains, oil redo, Sudan black, that is good for lipid storage. Pars is a good stain for Gaucher.
Gotcha.
And pearls is also a good stain because we generally do a pearl stain on all marrows, and Gaucher cells get highlighted by pearls.
Yes, sir. And one query from the student is, what is the final diagnosis in this case?
This, we called it as Wolman disease.
Wolman disease. Yes.
Yeah, Wolman.
Thank you, sir. I think there are
And
no more
it's-
questions for
okay,
this.
fine. So next case, the last one, who's now last means the third of my series, the last for me. Who will do it?
Sir, I'll take it.
You are?
Shiri.
Shiri, fine.
Yes, sir.
Case 6. Okay. So this was a 30-year male HIV positive who had fever for past 2 months, cough with hemoptysis, weight loss, night sweats. So the usual HIV positive, right? So what do you take on this? What is your take on this?
Sir, on the basis of history, we can say it can be a case of tuberculosis.
Okay, tuberculosis, fine.
Yes, sir.
There's pallor and oral thrush, fine. So what about the hematological parameters?
Hemoglobin is 4.5 gram per dl, which is reduced. MCV is 82 femtoliter, which is within the normal limit. TLC is 2300, which is reduced. On differential, leukopenia. On differential, neutrophil is 24, lymphocyte is 65, which is relatively increased. Monocyte is 0.4, and then meta is 7. Platelet is 34,000, which is again reduced.
Right. So there is some kind of cytopenia going on, as well as a bit of a left shift.
And
So neutropenia, thrombocytopenia, and anemia. Right. Very good. Okay. So this bone marrow, again, the indication I have given it to you: cytopenias and febrile illness. Fever of unknown origin.
Yes,
This patient was investigated for the usual viral profile, and otherwise turned out to be negative. So a bone marrow was done with the cytopenias and FUO. So this aparticulate and paucicellular. Can you tell us what would you do when you see a marrow like this? This is kind of representative of all the slides that we saw.
So this is basically, we can see that the bone marrow is paucicellular, and here the areas of fibrosis is also noted.
What are these? What are these pink strands that you're
So
seeing?
it can be a gelatinous transformation or the areas of fibrosis.
Fibrosis is usually, this is an aspirate. Okay, Shiri, this is an aspirate. So usually we don't get fibrosis, or the fibroblasts don't come out into the aspirate. We get a paucicellular marrow. But what do you think, anyone else, whatever is you thought this was a gelatinous transformation?
Gelatinous, yes.
They are usually not such fibular. Gelatinous transformation is kind of a homogeneous eosinophilic material. Anyone else, what do you think this is? Others?
Myxoid changes, sir.
Myxoid change. Anyone else? Okay. Anyone else?
Reticulin.
Reticulin, as I said, is not visible on an aspirate like that. It's very difficult to aspirate out the reticulin fibers. This is nothing but a fibrin strands, basically clotted blood, fibrin strands that have got caught, and some cells are there in this. So nothing much in the cell. It was a bad aspirate. In fact, such an aspirate, if you get, probably at the end of the day when you have got 100 slides to see, you would rather throw this into the dustbin and say that, no, non-diagnostic aspirate, I'm so happy. I don't have to bother my head, right? That's the general tendency. So let's look at it a bit closer. What did you see in this, Sheri?
So in this picture, we can see numerous negative shadows, maybe because of some organism like bacteria or any fungus.
Okay. Okay, fine. I hope all of you have identified these negative. Good that you picked them up. These negative images, as they are called, negative shadows of something which is rod-shaped. Yeah, something elongated and rod-shaped. Right. Okay. And the other background is kind of a dirty eosinophilic material in the background. Morphology of the cells are not very clear. So otherwise an unsatisfactory marrow. But it has these findings which are nice that you've picked up. Here again. Right now, what do you think, fungus or bacteria?
Sir, this I think is a past stain, which again is showing negative.
This is again Leishman, the routine Leishman genes. It's not past. It's not a past stain.
So again, we can see the negative shadows.
Yeah, they look a bit long, right?
Long, yes, sir.
Elongated, but there is no septation, no budding,
septation.
no like that, no nothing like that. So just generally elongated ones. Okay, so what would you do in this? Next, you've got
We will go for some special stain, like we can go for PAS stain for the confirming whether it is fungus or not. And also, if we are suspecting any bacteria, like according to history, it was like tuberculosis, we can also go for AFP stain.
Okay. So you want to do a pass followed by AFB, right?
Yes.
Anyone else?
GMS stain could be there done for
EMS stain. No, between pass and AFB, which one would you prefer?
pass because the filament.
Pass stain. Okay. Okay. I'll show you some more pictures. This was what do you see here?
So here, this I can see it is macrophage, which again in the cytoplasm is showing various negative shadows.
Right. Often this could be mistaken for a Gaucher cell.
For sure.
Pseudo-Gaucher kind of an appearance. Okay, so again, notice very carefully multiple negative images of broad shape. Similarly, this is possibly a myeloid cell.
Yes, sir.
Not
Again,
very
we
sure.
can
It's a
see
myeloid cell. Again, it shows the same thing.
negative
Okay,
shadows.
so now Zn stain or PAS stain?
So I'll go with Zn stain.
Now you will move to Zn stain, right? This was the trephine biopsy. I think again this picture was sent to you.
Yes,
This
sir.
trephine biopsy again shows, what does it show?
Sheets of macrophages can see on this
Kind of
part.
foamy, bubbly macrophages.
Foamy
What is this?
So this is an activated plasma cell.
So what does it show?
Plasma cell. The active
Russell
change
bodies.
maybe.
What are these? What are these structures called?
Russell bodies.
Russell bodies.
Russell
Right?
bodies.
Russell bodies. Right. They're Russell bodies. So there is a Russell bodies, and overall there is suppressed hematopoiesis. Right. I don't see too many hematopoietic cells. I'm seeing these sheets or clusters of these bubbly, foamy sort of macrophages. So basically, we did a bone marrow because of cytopenia and fever.
Yes.
So as findings, both of you have picked up. So next test that you would do would be obviously some kind of a stain that I want to do. So this same field, and that's the Zn stain.
It is positive.
Okay, so they are elongated, long. So what do you think are these when you look at such such bacilli, acid-fast bacilli?
As it can be atypical mycobacteria.
Yeah, so I'm sure you have seen the typical Mycobacterium tuberculous bacilli. They're much stubbier, shorter, beaded. These also are beaded, but they're a bit longer. So morphologically, they look a bit of the atypical kind of mycobacteriosis. Very good. So can you name one or two atypical mycobacteria?
Sir, Mycobacterium avium intercellular.
That is the one that commonly affects the marrow.
Commonly affects the
hematopoietic, and it also causes a severe erythroid suppression. Mycobacterium avium. That's why patients with Mycobacterium avium intracellular often have very severe anemia.
Yes.
So this was that macrophage which I saw, and this is the Zn stain. This is actually a very old slide of mine. I mean, I'm very fond of this slide. I've been showing it. So this was the first time we picked up such teeming mycobacteriosis in the bone marrow. This is, what stain is this? Looking at the color, what do you think the stain is? Magenta stain. That's PAS stain.
PAS stain.
This is PAS stain, and notice these bacilli are positive.
Are positive for PAS.
So Mycobacterium avium intracellular is Mycobacterium that is also PAS positive.
Yes,
so this was a case of an atypical mycobacteriosis, possibly Mycobacterium avium intracellular. Unfortunately, cultures were not done for this particular case, but subsequently we've got cases where they have grown avium intracellular. Okay, so this is again some more field. This is not the old case. It's a relatively new case that we had where we again saw similar negative images within the myeloid cells, and this is how it was: the acid-fast bacilli positivity, both intracellular and this is extracellular, inside myeloid cells. This was the trephine biopsy, another area, that same area, and another one. Again, foamy macrophages. These are kind of epithelioidish, if you notice, slipper-shaped nucleus. And this is the AFB stain, the Zn stain that was done. We have had one case, Dr. Rakhi also remembers, where it was even leprosy, lepromatous leprosy involving the marrow. So that could be kind of tricky. You'd need to do a fight for ACO stain and rule out. Okay, but these are basically tuberculosis or mycobacteriosis. So we report them as mycobacterial infection of the marrow. Rather than using the word tuberculosis, it's better to call them as mycobacteriosis. Get a culture if possible, or your other way of reporting it. Okay, so some other microorganisms that can be seen in the marrow are?
Sir, we can see leishmania.
Very good, leishmaniasis. So that's the typical leishmaniasis, high magnification. All right, right. The kinetoplast and the nucleus. This is histoplasma. Yeah, right. That also can be seen. These are all nicely pass positive, GMS positive, and this is another case of ours where a few macrophages held this. I'll show you on the hyper. Any idea?
Cryptococcus.
Excellent. Cryptococcus musicamen would have been positive. Right. So the take-home message of this case is that commonest opportunistic infection in HIV and AIDS is still tuberculosis, both mycobacterial and non-mycobacterial. The cellular response in mycobacterial infection can range from granulomatous to necrotizing to non-reactive. That's just basically neutrophilic infiltrate. As the immune status goes down, the bacillary load increases, right?
Yes.
So if there is a strong suspicion in a patient with suspected immunosuppression and infection, these smears are not really good. You do not get a good aspirate most of the time because there's so much of necrosis, so much of bacillary load. These aspirates are often unsatisfactory, but the diagnosis is there. It will be staring at you amidst all the unsatisfactory. So pay attention to these slides also, and you'll get your diagnosis. Right. So any other questions or queries?
Can I ask, sir?
Sure, please.
So in one of the picture, the organism, negative staining organism was quite slightly broader than the mycobacterium. Can it be mucormycosis kind of?
It was not enough thick enough to be mucormycosis. I know that. But then we read up the literature, the avium intracellular and the Kansasi, Mycobacterium kansasi, can be very long. I think you meant this particular photograph, right?
Yes, sir. Yeah, this one.
That's what I said. We did not get septations. We did not get any dichotomous branching, nothing. They do look broad, but then this is the same Zeden stain of this particular case. Okay. So maybe this picture I took under oil, so probably it is looking a bit broad and big. But these are all mycobacterium, and the atypical ones are can be longer, need not be beaded. So that's how it is.
Another thing, sir, can muco be intracellular, sir?
Which one?
Mucormycosis, can it be intracellular?
Intracellular, I'm not sure. I don't think so.
Yeah, sir. So in our case, it's probably mycobacterium only, sir. Then
yes, the mycobacteria. Without, I mean, what are the other acid-fast organisms other than tuberculosis? Any other organisms? Nocardia, which are of this shape, right? Nocardia, elongated. Otherwise, any other?
Organism, leprosy, lepra bacilli.
Okay, lepra bacilli. Cryptospora, very good. Cryptospora, right. Okay, so I think any other questions, Sindhura? Or
yes, sir. So many students had this query: what are those negative shadows? And I think we just confirmed that
what happens is the most of these mycobacteria have a lipid coating, right? The mycolic acid and all that doesn't allow the stain to penetrate. The routine Romanovsky stain doesn't penetrate into the bacilli, so they remain as negative shadows. Understood? Basically unstained bacilli. The stain doesn't get into the bacilli, but as you know, Zeden stain, once you do the Zeden stain, you will know that is what makes it acid fast, the mycolic acid. Understood? So the stain cannot penetrate. The routine Romanovsky stain cannot penetrate into the bacilli, so they look like a negative image.
Yes, sir. Sir, another question is, how does white stain help to differentiate between lepra and lepra bacilli and other mycobacteria?
The usual way white stain is used for picking up leprosy because it's less acid fast. I mean, the percentage of acid is less. So that same way, anything, and also leprosy in the marrow is very uncommon, but it can happen, especially in the lepromatous phase. But you know the basic difference between fight and ZN stain is the
Yes.
percentage of acid.
Less acid.
Yeah.
Sir, another question is, what should be the stain of choice for fungus among all the available special stains?
I think PAS still is good. PAS is a good stain. It highlights, and GMS is of course confirmatory. So between these two, you can use. Generally, we use both. Some of the PAS, especially the zygomycosis and all, are not too strongly PAS positive, but GMS is a good stain. Cryptococcus is mucicarmin positive, amongst the only fungus which is mucicarmin positive.
Yes. Sir, there is one question. In histopathology sections, Mycobacterium tuberculosis is also PAS positive. Have you faced any difficulty?
No. Mycobacterium tuberculosis is not PAS positive.
PAS positive. Yes, sir.
It's not PAS. It is only the avium intracellular, the atypical mycobacteria which are PAS positive.
Yes, sir.
Tuberculous bacilli are not PAS positive. They're PAS negative.
Yes, so that is how we actually differentiate between
Yes.
the MTB and the Mycobacterium intracellular.
Avium. Yes.
Yes, sir. So I think there are no more questions.